Hey guys, what's up? Okay, so this video is about amoebiasis. We'll see mainly the clinical features, what is amoeboma, what is amoebiasis, lab values, imaging studies, and treatment. So let's get started. So amoebiasis, this is caused by Entamoeba histolytica, and it's transmitted mainly by fecal-oral route while drinking or eating contaminated food/water. And this is the gross life cycle. So the mature cysts are the infective forms. They're ingested. It enters our lungs, literally, virtually all the organs. And the cyst and the trophocyte are again released through our feces. And once again, the cycle continues. In the initial part of the disease, there will be some non-specific symptoms such as abdominal pain, dry cough, fever, weight loss. Those are non-specific symptoms. Specific symptoms occur after that. There's this right upper quadrant pain, or there can be right shoulder tip pain, especially because of the diaphragm involvement and the same nerve supply. The supraclavicular nerve and the phrenic nerve have the same C4, which is what causing this right shoulder tip pain. There will be hiccough, sometimes non-productive cough too. So it is mainly because of travel. The tropical diseases have become prevalent worldwide. These are all the symptoms we saw. And then on examination, the person appears very toxic with anemia and jaundice. Per abdominal findings shows a tender hepatomegaly. So there's this hepatomegaly, okay? So there's this hepatomegaly. And sometimes there is intercostal space which are kind of increasing in size. Okay, we can see the bulge in the intercostal space. Plus, there will be skin edema, as in pitting edema like these, and sometimes ascites, sometimes pleural effusion as well. So these are all the examination findings we just saw. And then about the lab values and investigations, etc. So this is a typical picture which we see in colonoscopy. This is an ulcer which is seen. It is caused due to our amoebiasis. However, if the symptoms are going to be persistent, then we know we have to think about colonic cancer, because colonic cancer can be unmasked by amoebiasis. And what is amoeboma? Where it is present? Amoeboma is a chronic granulomatous condition caused by amoebiasis. It's mainly present at the cecum. And when we do a treatment, we have to continue it. Otherwise, in case of intermittent treatment, then amoeboma will form. On examination, there will be a mass in the right iliac fossa. That's where the cecum is present. Pyrexia is present. History of blood-stained and mucoid discharge, suggesting a history of amoebiasis all the time. Lab values suggest anemia, as we saw in the examination. WBCs are high, leukocytosis, elevated ESR, CRP indicating inflammation, low albumin and high alkaline phosphatase showing liver is getting screwed up slowly. Antibodies which are produced can be detected by complement fixation test, indirect hemagglutination, indirect immunofluorescence test, and ELISA. So this is a picture which is seen in sigmoidoscopy. Sigmoidoscopy can be done both using a rigid or a flexible sigmoidoscope. We can see a flask-shaped or a collar-shaped ulcer. It's called a collar stud ulcer. And on ultrasonography, there is this abscess cavity, which is kind of anechoic over here, and inside the core, there's hypoechoic lesions. Okay, that's the abscess. So this is what we saw. And this is anchovy sauce pus from a drain which is put up in the liver. So from the amoebic liver abscess, this anchovy sauce pus is leaking outside. In the CT scan, we can see there's this, okay, this is tilted. So there's this raised right hemidiaphragm. This is tilted image. So this is the right side. And here we can see pleural effusion, especially if the diaphragm is breached and then the abscess has entered into the lung. So this is what we saw. And in barium enema shows apple core appearance. So you can see here apple core appearance, apple core. And colonoscopy picture we already saw. So after treatment, we have to repeat the colonoscopy with biopsy after 3 to 4 weeks. Within 3 to 4 weeks, it will get better anyways. If it is still persistent, biopsy should be taken because colonic cancer. we have to rule out colonic cancer. So after that, treatment has to be initiated. Metronidazole, tinidazole will take care of the hepatic parasites, whereas the gastrointestinal parasite can be cured by diloxanide furoate. Aspiration of the abscess should also be done because abscess should also always be drained. Surgery is reserved only for complications, which means the main treatment for abscess is going to be medical rather than surgical. So we reserve it for complications like rupture, severe hemorrhage, and toxic megacolon. If it ruptures, it either enters into the pleural cavity, the pericardial cavity, or the peritoneal cavity, which is a complication. See you soon, guys. Okay, as always, guys, read Bailey and Love. It's a really good book. Comment down your interesting topics, the topics you're interested in, and make sure you click on that like button and that subscribe button. Share it with your friends, and as always, guys, stay on the bright side of life. Thanks.